Dr. Kelly Shaw's my name. I'm a public health physician and I've been helping the North Queensland Primary Health Network to prepare our Triennial Health Needs Assessment, and I'd like to share some of the findings from that Health Needs Assessment with you now. Firstly, I'd like to acknowledge the traditional custodians of the lands and seas on which we live and work and pay our respects to elders past and present. Primary health networks. There are 31 primary health networks nationally, and they have two key goals. They improve efficiency and effectiveness of health services for people, particularly for people who are at high risk of poor health outcomes, and they also improve the coordination of health services and help to increase access to primary care for people. The focus of primary health networks is primary care, and that's defined by the Commonwealth as treatment of non-admitted patients in the community. It represents the first point of contact for many people with the health system, and it's a strongly clinical definition of primary care. Each primary health network has to prepare a health needs assessment each triennium, and the purpose of the needs assessment is to help us to understand what our local needs look like, what the service networks look like, where the market is up to with primary health, and where we've got some opportunities to improve our health outcomes. And that helps us to make some decisions about our subsequent funding of various primary care services. Each PHN will prepare its health needs assessment according to the Australian Government guidelines. We get that approved by our executive and our board, and then we submit it to the Australian Government via a portal. They review it and approve our needs assessment, and we can then go on and undertake our primary care activities based on it. There are various ways to do needs assessments. For us, we look at our policy and strategy environment, we analyse qualitative and quantitative data, we consult with various stakeholders, and we put all of that information together into a priority setting process where we triangulate various issues from our needs assessment. And we pull together all of the information that we've looked at, align it with our organisation's strategic plan, the priorities in primary care nationally, within Queensland and regionally, and the priorities of our partner primary care organisations and hospital and health services. This is a snapshot of NQPHN strategic plan, and you'll see that it's got 5 main areas of activity. We are prioritising the mental health and alcohol and other drugs care needs of our population, and in fact that represents over 60% of our entire commissioning budget. But living in this part of the world, we also recognise that First Nations health is a huge priority for us, and we prioritise that also within our health needs assessment and in our commissioning activities across any commissioning that we do. Health workforce is a significant and ongoing challenge for us, so working to improve availability of GPs and other primary care professionals and their accessibility to people is vitally important for us, and we're looking for innovative ways to actually deliver primary care to people that make the best use of the available workforce that we have. We also work hard on system integration, and we use various strategies to try to improve communication and information sharing between different partners in the system. And we also have primary health, population health priorities, and within that we have a focus on the primary care aspects of prevention, promotion, and early intervention. So particularly the healthcare needs for mums and bubs, cancer screening, looking after biomedical risk factors such as hypertension, diabetes, those sorts of things. So in terms of the key findings from the data piece of our needs assessment, I'd like to share those with you now. That comes in 5 sections. There's a population health section, there is a section on chronic diseases, mental health, alcohol and other drugs, and Aboriginal and Torres Strait Islander health. And those 5 sections will be available in our comprehensive needs assessment document that we're producing and will have submitted to the Commonwealth Government by November 2021. The Primary Health Network has a very broad geographical catchment. We cover 500,000 square kilometres, and across that area we have 4 hospital and health services: Torres and Cape, Cairns and Hinterland, Townsville and Mackay. Our population comprises around 730,000 people, and of those about 80,000 are Aboriginal and or Torres Strait Islander, and 50,000 were born in countries which represent non-English speaking backgrounds. So we have a very culturally diverse, geographically dispersed population. But over 65% of our population actually lives in the 3 main centres of Cairns, Townsville and Mackay. Our population distribution looks like this. So if you look on the left side for our 0 to 4-year-olds all the way up to the 85 pluses, we have what's called a working age bulge. And this is a fairly common population pyramid among different communities. And what that means is people aged sort of 25 through to about 60 represent the largest number of people in our population. And the younger people coming through, who are the people who are going to look after us as we get older, they represent a smaller percentage of our population. So that's going to put some interesting challenges on the healthcare system and the entire care service system as we get older, because we need that younger population to look after us. Our population is also changing. According to Queensland government projections, by 2041, over the next 20 years, we'll have an additional 200,000 people living up in our region. So we'll get up to around 900,000 people. Most of those people are actually going to move into the major centres of Townsville, Cairns and Mackay. And because of the population demographic changing, the relative percentage of the population in the working age groups is actually going to drop relative to the percentage aged 70 years and over, which you can see will increase. Again, the older you get, the more chronic disease burden you have, the greater the care needs that the working age population will have to account for. Socioeconomic disadvantage is a really important risk factor for poor health outcomes. And if you take the entire Australian population and you split it up into 10% from the bottom 10% of the population to the top 10% in terms of income, what you'll find is we've got populations up here where the entire population would actually fit in that bottom 20% of Australia's socioeconomic status. So people in Cape Cook and Torres Strait, 100% of that population would fit into the bottom income quintile for our country. Mackay-Bowen, over 70% of the population, and Townsville, Charters Towers are a substantial proportion. That's important because poverty and socioeconomic disadvantage disproportionately increase your risk of poor health outcomes and of chronic disease, and that those poorer areas are priorities for us in terms of how we make sure primary care needs are met and how we make sure primary care is accessible to people. We use various measures to look at people's health status, and one of the sort of catch-all measures that we look at is called self-assessed health, and up here we actually have a fairly high self-assessed health. We also look at life expectancy, and compared with Queensland as a whole, life expectancy is lower across all of our hospital and health service areas, particularly in the Torres and Cape, but it is getting better over time. According to our 2016 census, about 5% of our population have a core activity restriction requiring assistance, or in other words, they need a little bit of help on their day-to-day to actually get through. And that profound or severe disability that people are experiencing is having a knock-on effect into the people that care for them. And about 1 in 10 people are actually providing care for somebody with a disability. Most of those carers are actually informal. They're not paid and it's not their main role. We also have pockets of low health literacy, and in some cases it's actually a younger population who are having disproportionately more difficulty trying to navigate our health system compared with our older population. Across all 31 primary health networks, we've actually got the 6th highest rate of premature deaths. And when you look at the causes of death, the 2 main causes are cancers and circulatory disease or cardiovascular disease. Compared with the Queensland average, in particular, Torres and Cape has very high rates of premature death from cancer and from cardiovascular disease. And down in our Mackay region, we've got higher rates of premature death from dementia. We're very concerned about this. This is our infant accrued mortality rate per 1,000 live births over time. So since 2011, the light blue line is Australia, the dark blue line is North Queensland. And you can see that over time, our infant mortality rate has varied, but it's remained higher than the Australian infant mortality rate. That's of particular concern to us because a lot of the way that we address this is actually through primary care. So we want to understand what the population health gaps are in primary care, particularly in antenatal and postnatal care, and how we can actually support mums and bubs to improve infant mortality rates. We know that 20 to 25% of women across our catchment have fewer than 8 antenatal visits. We have high rates of smoking and pregnancy in some populations, particularly in the Torres and Cape, and we have high rates of very low birth weight babies and premature babies. In terms of our demands for health services, they're increasing over time in our Cairns, Townsville and Mackay hospital and health service regions for public hospitalisations, and we're seeing palliative care admissions going up too in Townsville and Mackay. GP service delivery, in terms of the number of general practice services, so the number of consultations recorded by Medicare, since 2015 that's gone up rather dramatically. When we look at the actual number of people though who've received a GP service in that time, you'll see that it's not gone up quite as rapidly, which tends to suggest that the people who are accessing general practice are having more visits to the GP per year over time, and that makes us suspect that we're seeing an increase in chronic disease burden impacting GP service use. And then you can see in 2020 the impact of COVID on people receiving face-to-face GP services. And down the bottom, that's the telehealth Medicare benefit schedule use in the NQPHN catchment over time. So from 2015 to 2019, we saw 3,000 to 4,500 telehealth consultations being billed through Medicare, and then over 500,000 in 2020 when a new item number was introduced, or item numbers were introduced where we could make telehealth more available to our population. When we look at GP services across our various regions within the NQPHN catchment, we see that there's a lot of variation in services per capita that are billed through Medicare, the lowest being in the far north, where it's about 2.5 visits per year for people, and in the Cairns South area it's over 8 visits per person for the year. After hours GP services appear to be decreasing across the board, and they have been doing for some time. And when we again look at our variation in availability across our catchment, we see some variation, and particularly Cairns South has a higher availability of after hours than our other local areas. Not all allied health professions are captured in the data we get from the AHPRA database, but for those that are, we see some differences in the patterns of available hours of primary and community allied health in our catchment compared with Queensland as a whole. We seem to have relatively good availability of physiotherapy, occupational therapy and Aboriginal and Torres Strait Islander health workers, but we have lower availability for the other allied health professions. And when we drill down into local areas, we see not only a huge amount of variability per capita in the availability of allied health, but also the mix of allied health professionals differs. So for example, in the far north, we've got relatively low overall availability, but within that we've got high representation of Aboriginal and Torres Strait Islander health workforce, relatively low representation of dental workforce, and a relatively low representation of optometry. Aged care service demands on the way up. As our population ages, and that's a national and an international phenomenon. Within our population, the number of people aged 50 years and over with severe disability looks about the same as Australia as a whole. The number of people aged 65 plus who live alone looks about the same as Queensland overall, but represents 1 in 4 people who are relatively isolated through living at home alone. And our availability of residential aged care beds per 1,000 people and people over 70 years of age is actually a bit lower than the national average. Across our catchment, we estimate about 55% of people in permanent residential aged care have dementia. So in summary, in our population health area, our population's growing, it's aging, we're seeing high premature mortality from chronic disease, particularly cardiovascular disease and cancer. We've got gaps in primary care for women and babies, and our service demands are increasing across the board. We also have some fairly significant workforce shortages in primary care. When we think about chronic conditions and we look at self-reported chronic health conditions, the blue bars are the total adult population, and the most commonly reported chronic conditions actually in the musculoskeletal space, so back problems and arthritis. In the people aged over 65, chronic conditions, with the exception of asthma, are more prevalent, and particularly so for arthritis and musculoskeletal conditions. And this makes us think about what the primary healthcare needs look like for people who have persistent pain and musculoskeletal complaints, and what our priorities or opportunities might be to improve availability of musculoskeletal services for people with chronic conditions, and to find out whether persistent pain services and community are meeting people's needs. Cancer affects a significant proportion of our population, and it's one of our big killers. But when we look at the incidence of cancer across our population and we take out the impact of age, so we adjust the data so that it looks at what the cancer incidence would look like if all of the populations across our catchment had the same age structure. What we see is that prostate cancer is the most common cancer to be diagnosed, and our highest incidence rates are in the Charters Towers, Ingham area. We also have some variation in the incidence of melanoma, with high rates in Cairns North area. Breast cancer is fairly even across the board, but lower rates in places like Bowen Basin North and Far North. Our colorectal cancers are high in the Cairns South Port Douglas area, and then we see a lung cancer disease burden in the far north, and that's attributable to high tobacco smoking rates. When we look at cancer deaths per 100,000 population, lung cancer is the leading cause of cancer death. And compared with cancer incidence, we see some mismatch. For example, in the Bowen Basin North area, cancer incidence for prostate cancer was actually fairly similar to a lot of our other geographical areas, but the cancer mortality rate for prostate cancer is the highest in Bowen Basin North, and in fact is the third highest in the country according to these data. And that makes us wonder about the primary care needs for men in the Bowen Basin North area when they have prostate cancer, and whether we're getting to them early, we're getting their prostate cancers diagnosed, and whether they've got access to prostate cancer treatment. And similarly in the far north, bowel cancer rates were actually quite low cancer incidence, but they have the highest standardised cancer death from bowel cancer across our catchment. And when we think about cancer screening for bowel cancer is actually very preventable with early detection and with colonoscopy, and if we get it in the early stages, we can certainly improve cancer outcomes. So we have some work to do to understand what the accessibility of cancer screening for bowel cancer is like in far north, and how we can actually improve that. Some communities have high rates of cardiovascular disease, and when we look at the model prevalence of heart, stroke and vascular disease, our highest prevalence areas are actually mainly in our rural areas, such as Charters Towers, Air Burdekin, Bowen Collinsville. When we look upstream of that, some of the risk factors for cardiovascular disease are high blood pressure and diabetes. And when we compare our population across all of our catchment areas with Queensland and Australia, we've actually got quite high rates of high blood pressure or hypertension across our region. And when we look at our rates of type 2 diabetes, they're actually higher in most of our geographical areas compared with Queensland and Australia, particularly in the far north, but also around Innisfail, Yarrabah, Charters, Towers, Ingham, Air Burdekin and Serena. And we know that type 2 diabetes disproportionately affects people who are Aboriginal and or Torres Strait Islander. We look at selected hospital admissions for chronic conditions across our catchment, and we see that the number one reason for hospital admission is actually coronary heart disease, with the exception of Torres and Cape, where pneumonia and influenza are the leading cause of hospitalisation. We are trying to understand whether pneumonia and influenza vaccination, so pneumovax and influenza vaccinations, actually widely available, but we know that underlying a lot of this disease burden is the infectious diseases burden more generally, and that infection in and of itself is a priority, a primary care priority in Torres and Cape, and how we actually respond to not only pneumonia and influenza, but the broader infectious disease burden around skin infections, ear, nose and throat infections, Group A strep infection, which contributes to rheumatic heart disease and to post-streptococcal glomerulonephritis if you don't treat it. So we want to, in our next steps after our needs assessment, understand better how we can actually respond as a primary care organisation to supporting people on the ground in addressing that chronic disease, infectious diseases burden. And when we look at potentially preventable hospitalisations, they're divided up into acute, chronic and vaccine preventable. And we see that Torres and Cape is really disproportionately affected by vaccine preventable hospitalisations, but also has a very high acute and chronic disease, potentially preventable hospitalisation burden. Our North Queensland Primary Health Network has a very rich general practice data set, with the majority of GPs across the region contributing to their data to NQPHN. And across that data set, we have over 650,000 people since 1st of January 2017 that we've got GP data on. When we look at that data, there's an additional 30 to 35,000 people, though, who don't have a residential postcode that's within our catchment, and they come from all over the country. And that represents the, I guess, the nature of North Queensland as a tourist destination. So we see a lot of tourists, but also a large percentage of fly-in, fly-out workers, given the industries here. That represents about 5% of the entire general practice caseload in our GP data. So it's something that we need to account for in our health needs assessment and our planning for our workforce needs. People up in our catchment see the GP a bit less than nationally, 5.7 times a year compared with 6.1 nationally. We bulk bill a little bit less than nationally, and people in residential aged care facilities receive a bit less in terms of GP attendances per year compared with national figures. When we look at the types of things that our general practitioners are managing, it's mainly chronic conditions related. The number one thing that we see coded in our data is high blood pressure and high cholesterol, but number two is mental health problems, and nearly 40% of people accessing general practice actually have a recorded mental health problem. We also have a very high musculoskeletal disease burden, with over a third of people accessing GPs having at least one musculoskeletal disease reported. So in summary, we've got a large and growing chronic disease burden, and that we see a lot of geographical variation in terms of the chronic diseases themselves and the health outcomes of those diseases, but also how they're impacting the use of hospital resources. Our population growth and our population ageing are going to increase service demand because ageing is the biggest single risk factor for chronic disease. And we can see that our cancer screening also needs to improve. In terms of our mental health service offering, the disease burden for mental health is widely distributed across our population, and our data predate COVID. So we don't know what the impacts of COVID-19 are going to be on health service demand for people over time, but we anticipate it's going to further increase service demand. Based on our currently available data, people aged between 18 to 24 years are experiencing the highest rates of high to very high levels of psychological distress. And when we look at our Queensland survey data, we see that 25 to 35% of people in the Mackay, Cairns and Townsville areas are experiencing 5 or more mentally unhealthy days in any survey period. The low numbers in Torres and Cape we expect are actually a problem with the survey rather than a true reflection of the mental health disease burden. For people with severe and complex mental health problems, so particularly with schizophrenia or living with psychosis, they have a reduced life expectancy of between 12 and 16 years in females and males. And a lot of the contributor to that disease burden is actually chronic disease, particularly heart disease, stroke, vascular disease, diabetes. There's a cancer disease burden as well. And people who are living with psychosis and schizophrenia with that severe and complex mental health profile, they actually miss out on a lot of primary care. And we recognise that they're a priority for us to make sure that they have access to accessible primary health care to address that chronic disease burden. Suicide is not a mental health indicator, but we often look at it alongside our mental health data, and what we see is that across our regions that the age standardised rate of suicide is actually higher than the national average, and we don't have good data for Torres and Cape. In spite of our high disease burden and high prevalence and higher suicide rates, we actually have the lowest hospital admission rate for mental and behavioural disorders of all primary health networks in Queensland. The most common reason for people to be admitted to hospital for mental and behavioural problem is alcohol and other drugs, followed by anxiety. However, the thing that's responsible for the largest number of bed days and the people who stay in the longest is people experiencing schizophrenia. When we look at our emergency department presentations over time for mental and behavioural problems, they are fairly stable. In North Queensland, we see about 8,000 presentations to EDs each year. However, emergency departments aren't the ideal place to be looking after people with mental and behavioural problems for many people, and so in that 8,000 presentations a year there's an opportunity for us to look at alternative places for people to be looked after. Primary care has a large mental and behavioural disease burden that it looks after, and we saw before that almost 40% of people accessing GPs up here have a mental health problem recorded. Depression and anxiety in adults are the two main things that are being looked after. In terms of our psychology workforce and the full-time equivalent of psychologists across our population, they're not the only allied health professionals that are delivering care, but they are an important group of professionals whom we rely on for specialist clinical service delivery for mental health care needs and for psychometric assessments and other specific functions. And we can see a huge variation geographically in the full-time equivalent of psychologists. The Cairns South area has a very large availability compared with many of our other areas in our catchment. As a commissioning entity, we try to address gaps in services through our commissioning, and in the last triennium we delivered over 140,000 commissioned mental health services with our partners. Again, you see geographical variation in where we're delivering, and we think that there are some opportunities to make sure that we're reaching those geographical areas that have the highest need. For example, our highest rates of commissioning per capita were actually in the Mackay region, whereas when we look at Bowen Basin North and Whitsunday, which are also in the Mackay region, we've got much lower rates of commissioning. But given that they're more rural and that they have lower availability of psychologists, we need to do some work with our partners to understand how we can actually get some of that psychology out into those other areas. So in summary, our mental health disease burden is increasing. Chronic disease comorbidity is frequent and has a devastating impact on people with severe and complex mental health problems. It's got an impact on our hospital resources, and there's a disease burden there that could potentially be looked after in primary care instead of in hospitals and emergency departments. Primary care is already managing a large mental health disease burden, and we can see there's workforce maldistribution and workforce gaps, which is going to have a knock-on effect to how we can actually deliver mental health care into the community, because we have to work with what we've got and try to build up our workforce over time. And we've seen that our commissioning may not be aligned with the need or the market gaps, so we have to do some work understanding that better. Alcohol and other drugs, we look at with alcohol, lifetime risk associated with alcohol, but also single occasion risky drinking or binge drinking. And about 1 in 4 people in our adult population have a lifetime risk associated with their drinking, and over 1 in 3 with our binge drinking. Illicit drug use, we don't have highly local data. We're looking at Queensland as a whole, and that's problematic because patterns of use of illicit drugs vary a lot geographically. However, with that limitation in mind, if we have a look at the illicit drug use in the previous 12 months in our population, what we see in Queensland is that cannabis use has been fairly stable, that ecstasy use has varied a little bit over time, that methamphetamine use is on the way down, and that cocaine use is actually on the way up. Compared with the other PHNs in Queensland, North Queensland's rates of self-reported illicit drug use are pretty similar to the national rates. When we look at preventable harm associated with illicit alcohol and other drugs, though, alcohol use is responsible for the biggest disease burden of all of our drugs. It's also responsible for long-term and short-term health-related harms. But when you look at drug-induced deaths across Queensland, so much more proximally associated with death, what you see is our biggest number of deaths is actually opioid-related, and that they're increasing over time. Alcohol-related deaths have remained relatively stable, and with amphetamines, even though use is on the way down, deaths associated with use are actually on the way up. And when we look at hospital admissions associated with illicit drug use, amphetamines are really driving a rapidly increasing hospitalisation burden. A lot of that's because the nature of amphetamine use has changed over time. The chronicity of use has changed, and that the longer and more that you use amphetamines like ice over time, the more likely you are to develop complex problems like psychotic disorders, and about 50% of people eventually will develop an amphetamine psychosis. The way you treat that's to actually stop the amphetamines. Given their highly addictive potential, that's actually very difficult, and it involves a lot of specialised support from mental health and alcohol and other drug services working in a really highly integrated way. And in some cases, we've got addiction psychiatrists across the system who are actually carrying a lot of the highly specialised caseload in this. As a primary health network, our concern is to make sure that we're doing the bits that we can to prevent and identify people early with alcohol and illicit drug use, and that we're managing that alcohol related disease burden in primary and community as much as we can, so that our specialist services are managing the caseload that they really need to be managing. And when we look at our specialist AOD treatment services in our catchment, we're seeing that both government and non-government availability of services, looked at through a number of agencies, has actually gone up over time. The most common principal drug of concern, though, for specialist AOD treatment services in our catchment is alcohol. That's climbed slightly, and amphetamines are rapidly catching up as a common principal drug of concern. So what we'd like to understand is whether or not that alcohol-related drug burden in specialist AOD services, whether there's more we can do in primary care to commission community-based services to carry some of that load to enable our specialist AOD services to manage more of the amphetamine caseload that's coming through. And then finally, when we look at the rates of treatment for morphine as a principal drug of concern across all PHNs, we line all 31 PHNs up in a row, and what we see is that North Queensland is an outlier. So we do appear to have a specific issue with drugs like fentanyl, oxycodone, morphine, and methadone as a problem in our community. So the impacts of alcohol and other drugs on health outcomes and hospital resources, they vary substantially. The largest disease burden is alcohol related, and primary care has a lot to contribute in managing the alcohol related disease burden. But we have a problem geographically with prescription opioid misuse and death. The best available data we have from the Australian Atlas of Healthcare Variation suggests we don't have particularly high dispensing rates for opioids. So we need to better understand where the opioids are coming from and how they're actually contributing so much to harm, to understand what our options are to reduce opioid-related harm. And then finally, Aboriginal and Torres Strait Islander health. Our largest population of Aboriginal and Torres Strait Islander people is actually in far North Queensland, followed by Townsville, then Cairns, then Mackay. And when we look at the age structure of the Aboriginal and Torres Strait Islander population, that's on the left in yellow and orange, we see that they have a larger proportion of the population in younger age groups, and they don't have that working age bulge that the non-Indigenous population in North Queensland have. And that's partly because of the higher premature mortality, higher birth rate in younger age groups. When we look at specific chronic diseases and we compare Aboriginal and non-Indigenous people in Queensland to look at mortality, what we see is for every disease that we look at, a higher age standardised death rate in Aboriginal and Torres Strait Islander people. Particularly cardiovascular disease and cancer, but across the board with suicide, mental and behavioural problems, diabetes, lung problems, injury, which means that everything we've just talked about in terms of population health, chronic disease, mental health, alcohol and other drugs, that Aboriginal and Torres Strait Islander people are our priority within each of those priorities, as well as having specific primary care priorities themselves. Maternity care is less accessible to many mums in our catchment because we are so geographically diverse and we've got such a large rural spread, and because the Torres and Cape is a part of our catchment. Childhood mortality rates are still too high, and our infant mortality is still twice the rate of non-Indigenous people. Higher percentage of our Aboriginal and Torres Strait Islander mums have fewer than 8 antenatal visits and have more prem births and more low birth weight babies. Many women don't drive within an hour, don't live within an hour of a hospital or a public birthing unit, and there's lower accessibility of continuity of primary care and continuity of midwifery care for many women in those more remote and rural areas. So for us, that is a primary care need, because maternal health and maternity care are ultimately primary care. In terms of cancer burden within our Aboriginal and Torres Strait Islander population, cancer incidence on the left for some cancers like prostate cancer is actually lower, but when we look at cancer mortality on the right, the mortality is higher. So that incidence and mortality gap makes us wonder whether or not we've got some specific barriers to Aboriginal and Torres Strait Islander people accessing culturally safe, appropriate care to have their cancers diagnosed and managed. And of course, cancer incidence and mortality for lung cancer are very high in our Aboriginal and Torres Strait Islander population, and that's attributable to our tobacco smoking in our Aboriginal population. So as a population health priority, tobacco control and smoking cessation are significant and ongoing problems. We don't have local data available within the PHN on Aboriginal and Torres Strait Islander screening participation rates in our catchment, but when we look at Australia as a whole, we know that participation in breast cancer screening and bowel cancer screening is actually lower, and we anticipate that we've got the same problem here with lower participation in cancer screening. In our non-Indigenous and general population, it's our 0 to 18-year-olds who have the highest rates of psychological distress. When we look at mental and behavioural conditions in our Aboriginal and Torres Strait Islander population, it's actually the middle age groups between 25 and 54 where we see the highest percentage of people that are affected. When we look at our available general practice data within NQPHN, for the 82,000 Aboriginal and Torres Strait Islander people that live across our catchment, we've got data for over 80% of them, or people who identify as being Aboriginal and or Torres Strait Islander origin. They have a local postcode and they're accessing mainstream general practices within our catchment. So this is not Aboriginal medical service data, this is our mainstream GPs. And when you look at the age breakdown of that population, we see that it looks like the population pyramid, so largest representations actually in our youngest age groups. In terms of the geographical areas where we see the most access, Townsville is the #1 place where people are accessing mainstream general practice. And when we look at the chronic conditions that are being managed, unsurprisingly, asthma is the #1, given that the population's younger. That's not surprising, but in numbers 2 to 5, we can see mental health disease burden with depression, anxiety, and high blood pressure, high cholesterol, just like the non-Indigenous population are highly represented in our mainstream general practice data. With such high rates of utilisation of mainstream general practice services by Aboriginal and Torres Strait Islander people, we are concerned about the lack of data around the cultural safety of those services, and we have no information about the degree to which people are receiving Aboriginal medical services delivered care or ARCHO delivered care, as well as mainstream general practice, versus people who are electing to use mainstream general practice only, and the group of people who don't use either. So we think it's a priority for us to work with our partners to try to understand who's missing out on primary health care and whether there's anything we can do about that. But for people who are accessing mainstream general practice, whether they are aware of what the service offering within their Aboriginal community controlled health organisations is and whether they've got access to it. When we think about our commissioned mental health services, what we like to see is that we're commissioning into priority population groups, including our Aboriginal and Torres Strait Islander population. And ideally, our rates of commissioning for Aboriginal and Torres Strait Islander people per 10,000 Indigenous population would be higher than for the non-Indigenous clients, given that they're disproportionately experiencing the mental health disease burden. And in many of our local areas, they are. But in some places, we see a higher rate of non-Indigenous client participation. That may be because they've got excellent alternative services that we don't commission that they're accessing for mental health care. But we just need to, again, work with partners to better understand what's available to people in those areas to make sure that people's care needs are being met. When people do access our commissioned mental health services, we're seeing a really good outcome. So at baseline, almost half of the people accessing our mental health commission services who are Aboriginal and Torres Strait Islander are experiencing very high levels of psychological distress. But by the end of their episode of care, their treatments, an episode of care can be up to 10 visits. And what we see is that that's actually dropped down to just over a quarter of them are still experiencing very high psychological distress. So they appear to be very effective in supporting people, which is good news. In terms of hospital admissions for chronic disease, we see variation in rates of hospital admission for Aboriginal and non-Indigenous people, but the largest disease burden for both groups is in coronary heart disease, followed by our pneumonia, flu, chronic obstructive pulmonary disease is highly prevalent as well, and again that's evidence of our high tobacco smoking burden. In terms of our mental health admissions, alcohol and illicit drug use is the leading cause of hospital admission for our Aboriginal and Torres Strait Islander people across our hospital and health services, and age standardised rates of admission overall are higher for Aboriginal people than they are for non-Indigenous people. We've been working hard to try to increase Aboriginal and Torres Strait Islander participation in the health workforce. So not just health workers and health practitioners, they're vitally important, but across the board. We want to see more Aboriginal and Torres Strait Islander doctors and nurses and midwives and allied health professionals and managers and people in admin in all of the roles in healthcare. And what we see since 2006 across Queensland is that we have had some increase in the rate of Aboriginal and Torres Strait Islander people being employed in the health workforce, but we've also seen an increase in the rate in non-Indigenous people, and that rate's gone up faster. So we're not actually catching up with participation. And when we look at Queensland compared with other states and territories, we've got relatively low participation in the workforce by Indigenous doctors and by Indigenous nurses and midwives. Our Aboriginal and Torres Strait Islander health workers employed in North Queensland Primary Health Network, we've actually got higher FTE than Queensland and Australia, but we've got some maldistribution. So some places we have higher numbers of FTE employed, other places we haven't got any recorded. And we don't know if that's a data gap or if that's a true reflection of the workforce, and we need to do some work to understand what's going on there. So in summary, our Torres and Cape Hospital and Health Service region is the region within the regions in terms of health priority. It's got a substantial disease burden, unmet primary care needs. We haven't talked about specific sexual health, reproductive health, other sorts of health needs in this presentation, but certainly in our needs assessment, the written version, we've got much more detail about that. High morbidity and premature mortality from chronic disease and mental health problems across our Aboriginal and Torres Strait Islander populations. Impacts of chronic disease and mental health problems on hospital resources are varying geographically. We've got some gaps in our workforce, and we've got gaps in our identified health workforce. High levels of mainstream service utilisation, we really don't have any understanding of the cultural safety of those, and we've got variation in commissioned mental health service provision that we need to understand. So we've taken all of that information and we've been consulting with various stakeholders, and we've come up with priorities that align with our strategic plan, and they also align with each of those 5 areas that we've just talked about. When we think about our population priorities for the next triennium, NQPHN wants to prioritise making more equitable evidence-based resource allocation decisions to make sure that the resources that we have, which are limited, go to the places we need them the most. We've got prevention, promotion, early intervention priorities in population health. We have a specific stated priority around maternity, antenatal and postnatal care. Planned birthing or birthing is outside the remit of primary care, but certainly the antenatal and postnatal care components are within that, and we want to work with our partners to make sure that people have access to good care for mums and bubs. General practice and other primary care professionals, we have workforce issues across the board, and we want to work on those workforce issues, but recognising we still need to focus on our gaps. We've got gaps in rural, in aged care, in palliative care, in after hours, and they're specific priorities for us. And we're going to have to innovate. We don't have this workforce that's sitting there doing nothing that we can try to mobilise and get employed in these positions. We need to look for innovative workforce solutions that make the best use of the available capacity that we've got in the system. First Nations health is obviously a population health priority, and we've got specific population priority statements for First Nations people in a different section. And system integration. Each of our hospital and health services is required to complete a local area needs assessment and is undertaking their own planning activities, and we want to work with them to partner wherever possible, to co-commission wherever possible, to make sure that we're using our resources efficiently to try to address health care gaps. Health information continuity is an issue for us in some areas, and we need to improve communication information sharing between providers, and we want to improve our health intelligence capability. As you've seen, some of the data that we're relying on is Queensland based, or in some cases is Australia based, because we don't have local information to guide us. We don't want that to be the limiter that stops us from responding to these health needs, but we recognise that as we're responding, we need to improve our understanding of some of these health problems through the collection of health information. In terms of our chronic conditions priorities, prevention, promotion, early intervention, we're a primary care organisation. We think the primary care focus needs to be on cardiovascular disease, cancer, the two big killers within our population, and we want to work on biomedical risk factors and cancer screening. We also recognise, though, that musculoskeletal conditions disproportionately affect a large proportion of our population, and we need to understand what the promotion, early intervention, upstream options are to better support people with that. And given our opioid usage patterns, to make sure that we've got primary care persistent pain management services based on physical therapies rather than prescribing, that our primary care workforce can refer to and that our community members can access. In terms of GPs and primary care workforce capability, our focus is on our priority populations and on those priority chronic conditions, as we've just said, that disproportionately affect our community. So that's cardiovascular disease, cancer, chronic respiratory conditions, musculoskeletal problems, and mental and behavioural problems. In terms of system integration, we want to co-commission to respond to some of these chronic conditions priorities, and we recognise that digital health and solutions such as e-referral and e-prescribing will hopefully improve the accessibility of information to all providers involved in a person's care, and the use of My Health Record and digital platforms to improve the sharing of clinical notes and clinical records is still a priority. In First Nations health, we want to focus on maternity and postnatal care. We want to focus on sexual health and the infectious diseases burden in the far north. We want to build our workforce capacity and capability in our Aboriginal and Torres Strait Islander health workforce and increase participation by First Nations people across the health workforce. We want to increase service continuity in the Torres and Cape, where we've got the largest disease burden, the largest premature mortality, and some of the biggest challenges in delivering continuity of primary care. In terms of our approach and how we want to do that, we recognise the centrality of Aboriginal community control, and we want to support Aboriginal community controlled health organisations wherever they are in the system to improve primary care for their community. We want to make sure alongside that those Aboriginal and Torres Strait Islander people who choose to access mainstream services, that experience is culturally safe. We want to work with our ARCHOs to understand what cultural safety means, because it means different things to different communities, and how to best respond to some of those culturally unsafe practices that we hear about from our partners that are occurring in our system. And we're a partner in progressing Making Tracks, which is Queensland's health equity response and health equity solutions to close the gap and improve outcomes for Aboriginal and Torres Strait Islander people. We also, in our commissioning with our integrated teen care program, provide care coordination, multidisciplinary care and support for self-management through integrated teen care. And we want to adapt our approach to supporting integrated teen care to try to bring it closer to the ground and have it administered more closely within community wherever possible and through Aboriginal community control wherever possible. In the mental health and alcohol and other drugs space, we want to work again with our ARCHOs to improve access to mental health and alcohol and other drug services. There are other partner organisations that we'll work with too, but where we have ARCHOs in our communities, they have to be actively engaged and partners in the work that we do. In our social and emotional wellbeing support, we want to support ARCHOs in the delivery of their social and emotional wellbeing supports and implement the Joint Regional Wellbeing Plan for North Queensland, which will enable us to participate in partnerships around improved wellbeing. And we want to improve the capacity of the mental health and alcohol and other drugs mainstream services to make sure that their offering is culturally safe, and that includes general practice. Mental health priorities, it's a short list but a big job. It's about implementing our mental health stepped care model, and there's a lot of information on our website about that. Supporting our community-based suicide prevention activities and initiatives, and improving access to mental health services, particularly for our young people. And then finally, in the alcohol and other drugs priorities, we want to build the primary care capacity of the AOD treatment sector. That's going to involve, again, workforce development, increasing availability of community AOD services, building our health intelligence to understand our own unique alcohol and other drugs usage patterns, issues and challenges, and building integration with specialist alcohol and other drug services so that we can make sure that we're calibrating our system correctly so that the specialist AOD services are doing the bit we need them to do, and that as a primary care organisation we're supporting primary care to do the bit that primary care needs to do. So that's our snapshot on our health needs assessment so far. It's not complete, and your feedback is greatly appreciated. So coming out with this presentation, we'll be providing you with access to a QR code and a survey form where you can provide us with your perspectives on primary care need and primary care priorities, and we're very keen to hear from you. The final needs assessment goes up to the Commonwealth by the 21st of November. So any feedback we receive before then is appreciated, but even if the feedback is received afterwards, this is only the beginning of the conversations. As you can see, it's not the end, and we'll hopefully be able to work with you to continue to hear what you've got to say about how we can actually respond more effectively as a primary healthcare network to improving primary care outcomes for people. So thank you for watching.